Hello, my name is Jocelyn Smith, and I will be giving this presentation in front of one tiny person and three other young people within my audience for Communications 125. The name of my speech is the art and science of easing a child's pain. Pain has always been a challenging subject in the medical field. Sorry, hold on one second, guys. Pain has always been a challenging subject in the medical field. With the ongoing opioid epidemic abuse factor, it's often tied to a lack of proper pain management, which makes this a very difficult topic to demand focus for. But I want for you guys to imagine if you were the parent of a child that has pain, a very small child, such as your sister here, who is not really capable of communicating. And no amount of you being able to console her eases her pain. This is the challenging reality that patients face and parents face on a regular basis, by which the skilled compassion of pediatric nursing comes into play. As a nurse and nursing student, I have firsthand seen the unique and often heart-wrenching challenges of pediatric pain management and the incredible tools that we have to utilize in order to provide the comfort that a patient may need. Today, I will explain how nurses navigate the distinct challenges of pediatric pain management and assessment and apply a diverse range of interventions to ensure our youngest patients are comfortable and that their needs are met. To fully understand the critical area of care, we'll proceed in 3 steps. First, we will explore why assessing pain in children is so challenging. Secondly, we'll look at the specific standardized tools and scales nurses have to use in order to measure pain. And then we'll conclude by discussing the different interventions, both medical and non-medical, that nurses use to truly alleviate a child's suffering. So the unique challenges of pediatric pain. When a child is in pain, it's not like an adult who can simply say, my pain is an 8 out of 10. The act of assessing pain in a complex puzzle is a complex puzzle that requires keen observation and insight. The first major obstacle to this challenge, especially of nonverbal patients, like infants and toddlers, simply cannot verbally express their pain, who simply cannot verbally express their pain. This means that we cannot rely on a direct question or statement from the patient. We instead have to rely on observational cues. We look for the changes in a cry pattern, or is the pitch high? Is the pitch of the cry high, or is it constant? We observe body movements, such as their legs being rigid, or are they thrashing with rapid body movement? And most importantly, we look for their facial expressions. Are they grimacing? Are they farrowing? Are they brow? Are they making a face that makes it easy for us to distinctly tell what the concern may be? Are they guarded in any way? Are they guarding one area of the body compared to another? Even once a child learns to speak, the challenges continue due to developmental and cognitive factors. A child has limited vocabulary to describe pain at first. They might say it hurts, but they can't always describe sharp or stabbing or dull or aching sensations. Furthermore, the perception of pain varies greatly, of course, by age. A 2-year-old processing pain is different from a 10-year-old processing pain. Compounding this, children may even deny pain out of fear of getting a shot or bad tasting medicine, or even having a fear of having to stay within an environment such as the hospital longer than they would expect, which can also, with these factors, this can also help, the pain assessment can also help in pediatrics for a nurse to basically attain the patient's pain level and make the task a lot less harder. To move beyond mere guesswork, we then specifically have to use evidence-based tools. As a multi-site survey study found, the use of pain management tools has been significantly beneficial because in the end, pain is considered a self-reported vital sign. These tools help to translate both nonverbal and verbal cues into a manageable, objectable score. We utilize several standardized scores, including the Wong-Baker Face Pain Rating Scale, the numeric rating scale, and the Colorado Behavioral Numerical Pain Scale for sedated patients who basically are not able to speak, like the ones that are in a coma or under heavy sedation as a means of, basically medically keeping the patient stable. Let's look at how two of these scores work, or pain scales work. The Wong-Baker Faces Pain Scale is a fantastic resource for young children. The patient is shown a chart of 6 faces, ranging from happy, which can mean 0 pain, to a face of crying, which could be a 10 out of 10 rate of pain. The child simply points to the face that matches how they feel in that moment. This not only helps the younger child process the pain as a drawn expression, but also aids the nurse in identifying a proxy score, even in nonverbal patients. Now, the numeric rating scale, this scale is typically reserved for an adolescent child who is a bit more cognitively mature to understand abstract numbers. And the child is simply asked, how do you feel on a 0 to 10 scale, making it easy for the patient to identify that the number 10 is greater than a number 0. 0 is no pain at all, and 10 is the worst pain imaginable. The simple question helps the child quantify how small or large the pain could possibly be. And we'll identify, or we'll kind of go over the Colorado Behavioral Numerical Pain Scale really quickly, just for a bit of background information to help us in our next portion of the explanation of speech. So its purpose basically is specifically to assess a patient who cannot communicate verbally due to sedation and severe illnesses. Instead of asking or pointing, it really is dependent upon the nurse to identify physiological interaction or indications of pain, such as an elevated blood pressure, respiratory rate, or an increase of heart rate. This transforms objective vital signs into a pain score when communication is impossible. Okay, and so once the pain is assessed, the nurse's priority shifts to the intervention, which involves a multi-module approach combining both non-pharmacological, which is basically no medicine, or techniques of pain management without using medicine, and pharmacological treatments, which is medication management. Non-pharmacological intervention techniques used outside of medication to help treat pain for infants could be things such as holding, rocking, or swaddling. For older children, it could be as simple as distraction. This includes using bubbles, toys, music, telling stories, or even playing games. These simple methods are used not only to treat mild pain, but also make scary procedures like injections or placing IVs easier to tolerate. Research shows that these interventions, such as oral sweet solutions, non-nutrient sucking, or even skin to skin contact, which is basically like what we're doing here, where, well, sort of, she's touching my arm and my arm is touching the skin of her back, which provides her comfort in a moment when she could be definitely most anxious. They have the potential to alleviate stress during procedures and even improve effectiveness of medications, potentially reducing their overall use. For pharmacological interventions, when the non-pharmacological interventions are just simply not enough, we have to use medication intervention. This often starts with over-the-counter options like Tylenol or even Motrin. Sometimes even like a topical cream like Bengay or Aspirin. The goal is always to use the least invasive and most effective drug possible. For those severe or chronic prescription-based medications can be used, which would be placed through the IV or could even be given as an IM injection for more likely more invasive procedures or trauma that is caused to the patient. Nurses are critical in safely administering these medications and constantly monitoring the child for relief and potential adverse effects of the medications. In this speech, we have covered unique difficulties in assessing a child's pain, namely their nonverbal or limited communication. We then reviewed the various standardized scales like the faces and numerical scales that nurses use to measure that pain. Finally, we discussed the powerful multi-module approach of interventions utilizing both comfort measures and pharmacological or medication management for relief. By using these specialized tools and techniques, nurses can effectively and compassionately manage pediatric pain, ensuring our most vulnerable patients receive the best possible care, tailored to what they need, not just to what they can say. The next time you see a nurse comforting a crying child, remember this: beyond the simple, compassionate act of care, there is a science and an art to truly understanding and alleviating what the little one cannot say. We work hard to ensure that no child suffers in silence. And I do thank you for listening to everything that I have had to say, and hopefully that gives you something to think about the next time you see someone in distress.